Great. Thank you very much, Bridget. And good afternoon, everybody. Lovely to be with you again on this, must say, for a change, sunny afternoon in Cape Town, which is wonderful, beautiful outside, and great to be with you all. So today, we once again have our weekly deep dive meeting. For those from other specialties who are joining us today, welcome. For anyone who's here for the first time, I want to really encourage and invite you to subscribe to the invites every week. If you are here for the first time, there will be an opportunity at the end to give feedback, and probably when you're registered, you already put in your email address. So that's great, and we will let you know about the topics of every week. Today, we are taking a slightly different slant, where we're looking at supportive care in hematology, and we have somebody really fantastic to speak to us about that, very well known to all of us in the hematology community, Dr. David Britton. And so David, for those who don't know him, is clinical hematologist and also director of ActLife Hematology at Netcare Pretoria East. He's the former chairperson of the South African Stem Cell Transplant Society, and really one of the leaders in hematology in the country, and just a wonderful, wonderful, caring person who knows his stuff. And I think today is going to be a great opportunity to learn from David, not only in the theory, but also from his personal experience. He's been around for a very long time. Bridget, maybe we could just go back to the earlier slide. Sorry, I jumped over it. So also, many people ask afterwards where they can access the recordings. Please go and have a look at the website, bloodsa.org.za, under resources. Every week's session is recorded and then uploaded there, especially for those who are in training, and a reminder, this is really aimed at our trainees in clinical hematology and hematopathology, and also internal medicine or other specialties. From time to time, we do topics relevant to many other specialties, so keep your eyes open. Please take part. This is not meant to be super formal. Please put questions in the chat box, comments, your experience. We're always keen, if you've got cases that you would like answers for, this is the opportunity. If you want to add someone to the mailing list afterwards, or you tell somebody about the meeting and they're not on the list yet, please take down Melanie Davids' email address. You can definitely contact her. She will happily do that for you. And then also of note, the CPD points, if you're South African, are automatically submitted to the HPCSA, but the system works like this. It measures your attendance time. You've got to stay on board for 1 hour minimum to qualify for the CPD point. Otherwise, it doesn't actually send your details to the HPCSA. So please make sure you stay for at least an hour. And then we really appreciate your feedback. So the opportunity will be there at the end to give some feedback. Please do so. It'd be really great. And we've really used this feedback over the last couple of years to try and improve our sessions. Next slide. So, important reminder, and I really want to emphasize 1 or 2 points here. So on the weekend of the 13th to the 15th of September at Century City Conference Center in Cape Town, we're hosting our 16th annual Hematology Oncology Symposium. Now, for many years, we have worked very hard at getting everybody in the field of hematology closer together. And this year, we're taking it a step further and really trying to include both benign and malignant hematology, clinical and laboratory hematology, and we will have speakers from all sides. And I think there is going to be, not think, I know, I happen to know what the program looks like. We're having the most phenomenal speakers, both many international speakers, many local speakers from all different parts, private, public, pathology, clinical, and whether you're interested in bleeding or thrombosis or transfusion or cancer, doesn't matter. There's going to be something for everyone. And please make sure you go to the links on the Blood SA website, look at the program. You will not be sorry if you come. So that's just a reminder for that. Then next slide. Big thank you once again to our team. Prof. Stelverberg, who's the deep dive team leader. Gerdien Kritzinger, who's on maternity leave at present, but the national training coordinator. Melanie, who does the CPD. And Bridget, who is doing the national coordination and a lot of the organization. Thanks very much to all of you. So with all that said, it is the moment you've all been waiting for. And David will speak to us today on chemotherapy-induced anemia, as well as ITP, immune thrombocytopenia. And then next week, I want to just give a heads up. We're going to have a talk on PNH and the role of complement pathway inhibition. Super hot topic for all the trainees with all the new complement pathway inhibitors and inhibitors of inhibitors. So a very exciting time to learn more about that. That's for next week. Right. And I've introduced David. And with that, David, I hand over to you. Thank you so much for agreeing to talk to us. And thank you also to Aspen, who I believe sponsoring this session today. Really wonderful. Really appreciate that. And I'm going to let you take over. Thanks. Bye.
Great. Thank you, Vernon, for your very generous introduction, and nicely covered on the talk. I mean, the conference that's planned. We're looking forward to the kind of expanded and new or more inclusive program. So I think all of us in clinical hematology have interests outside of just malignant disease, and also in terms of the laboratory aspect of things, especially for the clinical hemes. So I think that's going to be great. That's a great advancement. I've misled you a little bit because Aspen wanted me to talk about the use of romiplastin in chemotherapy-associated thrombocytopenia, and of course not registered for that. And what? Let me just get that topic out of the way straight away. So, and we were never really planned on discussing ITP, but back at the time of COVID, we were worried that there might be a shortage of donors for blood and platelet donation, and so we initiated a program of preemptively using growth factors for our transplant patients. So I think everybody uses some GCSF, but we decided to use some EPO and TPO, and in doing so, we then evaluated it compared to the year before. And as many negative findings don't ever really make it into the literature, this negative finding was prepared as a poster for Heme Onc one year, and it never reached fruition. But essentially, the numbers were probably a bit too small. There was a shortening in engraftment time for platelets, and that was most marked in the haploidentical program. And there was a reduction in platelet transfusions and likewise in the erythropoiesis, there was a reduction in the number of units used by nearly 1. but neither reduction was statistically significant, and so that poster didn't ever see the light of day. But just so that we can know that these things are and can be used in that sort of setting. Aspen is really worried, as they rightly should be, that I will say something that is off-label and not necessarily 100% in line with their product, because, as we all know, these things don't always stick strictly to the package insert. So they are not responsible for what I say today. This is me. Okay, so everyone knows that what anemia is, and that it's really the most common and persistent hematological abnormality that we see in patients receiving chemotherapy. And this is because many of the drugs are myelosuppressive, and they sorry, just want to give myself some space here. And they give and they suppress the erythropoietic component of the bone marrow, and as such lead to anemia. And some drugs and some diseases are worse than others in this regard. As a kind of rule of thumb, the more advanced the disease, the worse the anemia is, and the worse the prognosis is. And the leaps of logic that people make, and one has to be cautious of, is that if you reverse the anemia, that you will improve the prognosis, and that's not necessarily always true. We know that, for example, radiotherapy is more effective when the person is less anemic or closer to normal. But at the same time, there is some evidence that there's an increased risk of disease progression in people who have erythropoietic stimulating agents, and we're going to spend some time discussing it, thrombosis. So because of this impact of chemotherapy and its impact on the patients, both in their quality of life, but also as an impact on their treatment. And so treatment can be delayed because of myelosuppression, as one knows. And I think perhaps the best data on the negative side of delaying treatment is that a 20% reduction in the dose intensity of ABVD for Hodgkin lymphoma results in a 50% increased risk of relapse in Hodgkin lymphoma. So delaying treatment is not necessarily a okay thing to do, and it's something that we, particularly in the early part of the treatment program, should try to avoid where we're safe. And that's what we want to use these drugs for, is to maintain that safety. Unfortunately, we, as clinicians, often have the kind of approach that, well, you're getting chemotherapy, you're going to feel a bit crap. And sorry, that's probably not a PC word to use. You're going to feel a bit tired. You're going to feel a bit fatigued. All your other symptoms, that your arthritis and muscle pains and things that you have anyway are going to be worse. So just to keep that in mind, is that not to just be too blasé about it, and to understand there are things that can be done about it. Okay. So how common is the problem? Well, it's probably at least 50% of people that are receiving intensive chemotherapy regimens will be anemic. And of those, most of them will be symptomatic for at least a few days of the month, and a substantial proportion will feel tired on a daily basis. I mean, HB is not something that just goes up and down, so that's not surprising that that would happen. And then, of course, the associated symptoms of anemia, which, and sometimes we forget that as well. A patient says, oh, I've got a headache. I've often got a headache. Actually, it may just be the anemia. Tired, can't do the things that I want to do. And in South Africa, where the age demographic tends to be a little bit lower, this may impact on family life, etc. We all know this line. It's supposed to be an S curve. And if you use a bit of imagination, you can see that is that your quality of life doesn't really go up between a hemoglobin of 7 to 9. And then from 9, as you pass through 10 to about 12, you get a kind of relationship improvement. The better the hemoglobin, the better your quality of life score. And then once you get to above 12 or so, the improvement in HB doesn't really give you an improvement in your quality of life. And that's no real surprise, is that below sort of 8 or 9, you're so tired that you can't really grade it. And once you get above 11 or so, you start to improve your functionality, and it stops being a limiting factor. As I pointed out earlier, that anemia may cause a dose delay, and its risk for those patients who've got HBs of less than 2 is around about 1.5 to 2 times that of people who are above. So significant anemia results in a significant delay in treatment. Okay, so how do we grade the anemia? This stuff's all very basic and most of us know it, but it's nice to have it kind of structured. And I must say, I thought this is going to be a talk that in preparing, I wasn't going to learn very much about, and I was surprised that there was stuff to learn about or to remember about. So I think most of us would say that an HB of above 10 is, 9.5, 10, we wouldn't really react too strongly to, and unless the person is symptomatic, we probably wouldn't really get too worked up about it. That would be mild. But once hemoglobins are dropping below 8, we would start to get a bit worried, and certainly hemoglobins of 6.5 or less make most people sit up. What's important here is perhaps that group of people who have mild anemia, but have other comorbidities that would require, and so they're just a bit more sensitive to the anemia. They have cardiac problems, they have neuropathies, they have fibromyalgia, pain. So you want to feel your best if you're dealing with other problems, and the anemia just makes it worse. This is a little bit of an exaggeration, this graph, in that it's saying half the patients have anemia, sure, but for the majority of those, the majority of the ones who have anemia, it's mild. So, but moderate to severe starts happening in about sort of 15 to 20% of cases. Here we're choosing the cutoffs are slightly different to the other grading system. But here you can see it quite clearly. And there are some diseases that are worse, lung cancer, ovarian cancer, probably because these use platinum-based regimens, lymphomas, because the treatment is quite hectic on the hemopoietic system. It's targeted against that. And I mean, we're not even counting things like leukemia treatment, etc. But on average, around about 10 to 15% of people will have moderate to severe anemia. And that means that they're very symptomatic of it. And this group above, the other sort of 15 to 20% are the ones that you need to also consider how symptomatic they are, and would they be better? Okay, would they feel better if their HBs were higher? We talked a bit about this. Basically, what I was saying there with the platinum-based regimens have got quite a high level of anemia and quite a high level of severe anemia. CHOP is pretty much up there as well. Okay, and obviously, if you intensify the regimen, you notice the problems a little bit more. So, how many of these patients that actually have anemia get treatment? And the majority don't. So we just shrug our shoulders and say that's fine. Some of them will be mild, and so probably don't need it. And remember, there's a cost to treatment, not just financial, but there's a burden of administering the treatment and there's a financial cost of it as well. But around about 40% of people do get treatment. Of those, 40% each would get either transfusions or erythropoietin, and some would get iron alone, around 10% of that group. And how do we apply that? We're going to spend a bit of time talking about that. Okay. So those are the three real options for treating anemia. You can transfuse them, you can give iron, and you can give erythropoietin, or a combination of these. So red cell transfusions we're all very familiar with. The sort of standing joke about transfusions is that if patients were, if you were to try and register it as a treatment today with SAPRA, FDA, EMA, they would laugh at you. They wouldn't let you do the phase 1 trial. So, but we have it. It's on our list of available therapies, and it has some great advantages. I mean, we all use it, and we've all had to deal with patients who hamstring the treatment program by saying they won't have transfusions, and we'll talk a little bit about those as well. So in patients who have hemoglobins of less than 9 or are very symptomatic, the advantage of transfusions is that it usually corrects the anemia immediately. And if it doesn't, you need to look for some other cause for the anemia than just the chemotherapy-associated problem. In patients, though, who can wait a little bit, have milder symptoms or have less serious comorbidities, then erythropoietin or erythropoietic stimulating agents can be considered as a real option. How are we doing for time? We've got to get this to an hour, otherwise nobody gets CPD points. I got the warning there. Thanks, Vernon. So this is a typical sort of HB curve of somebody who's got severe anemia and needs frequent transfusions. What we see here, this patient jumps from 6 to 11, and slowly over the next month trickles down back to 5, a little bit of a jump, not enough, gets a bit more, back up to 12. They must have got a hell of a whack that time, and then slowly trickling down to 7 again, and then back up with these. And this is a typical curve because you haven't addressed the underlying cause of the anemia. The patient's still getting chemotherapy, and until that is done and it is sorted, they will have problems. There are some potential unwanted effects. So the main one is that it's iron. I mean, we know that 2 units of blood have your annual requirement of iron. You can increase your absorption a little bit if you donate blood 4 to 6 times in a year, and you won't necessarily become iron deficient. But that's a lot of iron that's in 1 unit of blood. And the other thing is it's packaged in a way that your body's ideally situated to handle it. Your body knows how to break down old red cells and to recycle the iron through the biliary system. And so you really do store that iron. And so patients who get a lot of iron over a long period of time become very rapidly iron overloaded. There's an increased risk of infection, and the obvious one is that the product may transmit an infection from the donor, but it's a great culture medium, and so very stringent sterility is required through the whole process of managing a blood transfusion from its collection through to its administration. And that's a lot of steps that can go wrong, and probably something that we underdiagnose, but nonetheless not that common. And then what we also forget sometimes is that patients who get transfusions are at higher risk for the infections in the environmental infections, the iron overload, and the immunosuppressive effects of the transfusion being blamed predominantly for that. The other thing about blood is it's expensive and not always accessible, particularly at critical times like, sort of holidays, national holidays, at times when donors also go on holiday and patients tend to injure themselves a lot more. So what is the American Society of Association of Blood Banks recommend? They say that one should maintain the hemoglobin above 7 and consider transfusions in patients whose hemoglobin is less than 8. I think in South Africa over the years, we've shifted quite a lot from and perhaps internationally as well, as to what the target is. And we're a little less rigid about an absolute number. But I must say, I tend to get a little bit edgy when people's hemoglobins drop below 8, especially if the cause isn't imminently reversible. I really don't get too excited when I get a patient who's got a long history of, say, Crohn's disease, or and they come in with an hemoglobin of 4 or 5, and they're completely compensated, and it's related to either iron deficiency or B12 deficiency, and you replace the deficit as well as other hemoglobin now going to be needed at plenish. And I don't become acutely anemic because of their chemotherapy or their disease. My Zoom is telling me I'm unstable. Can you guys hear me?
There's been some interruption, David.
That's a bit worrying.
But yeah, let's continue. It sounds like it's not been very long-lived.
So the patients who've had a sort of fairly rapid decrease, maybe a bit older, may have comorbidities like ischemic heart disease or cerebrovascular impairment. We don't want those people to be, and just, you stopping treatment and you can get going. You want to keep those people in a zone where they are less symptomatic and they're less at risk for a complication of their underlying comorbidity. And then I would edge back towards the sort of more traditional value of 10, especially, as I say, in older people who've had CVAs before or ischemic heart disease. And I think that most of us would prefer that kind of approach. But it does mean that you have to be paying attention to the patient and monitoring them, and not just letting their wives speak for them, as sometimes happens with the patients. Sorry, that was supposed to be tongue-in-cheek, but anyway. So there are some serious problems related to transfusions, and the acute sort of infusion reactions are quite common. Probably about a third of patients get some form of pyrexia, and especially those that have been repeatedly transfused. I must say, I don't think we see delayed transfusion reactions at that rate of 14%. I would say that's much less common. Maybe we don't look for it that much. But and I don't think we see graft versus host disease at a level of 2%. Remember that most centers use leukodepletion filters, and even in immune-compromised patients, the ability to eradicate an offending lymphocyte that's not matched is quite high. The main risk with that is actually one of the reasons to be cautious of directed transfusions, and that is family members who share a high proportion of the family members who share a high proportion of the patient's HLA group, and may be isotypic in areas where they rather than not than being discrepant, those patients may slip under the radar. But again, I don't think it's a very common thing in South Africa. I mean, we do get requests for directed transfusions, but not often, and it's not a very practical solution in oncology and hematology because of the frequency and of the requirements of transfusions. Acute lung injury, I think, is probably underdiagnosed in our setting, especially in the more seriously ill patients. I think we probably miss that a little bit. And then I don't think that we have 50% of the adverse reactions are due to clerical errors. I do note that this reference is 1999, and maybe with better electronic systems, it's less likely to happen. But I don't know. I'm happy to have that as a discussion point later on to see what's happening. I see somebody asked here about the radiation. For radiation, I think the generally accepted level is the patient should have a hemoglobin of above 10, but maybe somebody else will have an opinion on that. Okay. So what about iron? So iron is absorbed in the intestine and then transported to the bone marrow stores where it's used to make red cells. And as red cells age and die, they get chaps by the macrophages in the spleen and recycled, and the iron gets recycled. If you have an excess of iron, it starts to get stored in the liver. Initially, the liver acts as a sump for extra iron, and this iron is also fairly available. You see the two-way arrows so that you can get it back into the hemopoietic system. What's important here is that you can get a functional iron deficiency where you're not using your iron because you're sick, because you're getting chemotherapy. And to some extent, that can be overridden by a little bit of pressure. And like you can give a little bit more iron and you can actually improve the hemoglobin, even in people who have got iron in the normal range. And on the normal range, I'd like to just pose a point that if you note, women have a lower iron range than men do. And I can't think of any physiological reason that it would be acceptable to have a lower iron level. There's obviously reasons that women have lower levels, and that is, the menstruation and the pregnancy and lactation, and perhaps a poorer diet in terms of red meat that may contribute to that. But from a hemopoietic point of view, there's no reason that women should have a lower iron. And so in patients that are anemic, I tend to aim to rather get the iron closer to the middle of male normals if you want to try and get iron, if you want to get the best hemopoietic response from patients. And that's true of all forms of anemia. I think that one should try to aim for that. Of course, the ferritin can be a little bit difficult to interpret in people who've got inflammatory malignancies or have got malignancies now with infections or other injuries, radiation burns, extravasation injuries, tephlitis, etc., etc. Okay. But and then the other point is that often oral iron is not very well absorbed. Oral iron is fine in patients who are mildly iron deficient and who have, have got normal functioning hemopoiesis, like younger pregnant people, athletes, that sort of group of patients. But in people who are receiving chemotherapy, who are already a bit nauseous and having GIT disturbances, oral iron tends to be a lot less effective in terms of getting iron replenishment. And so reaching for the IV iron, although a bit more expensive, is a hell of a lot cheaper than blood. So the cost of a unit of red cells is around about 5.5 to 6,000 rand in the Sandbus area, and I'm assuming it's something similar in Western Province. And platelets are around about 14,000 for a pooled unit, and around 15.5 for an apheresis unit. Platelets are not cheap, and nor is blood. And that's without the admission for infusion, etc., etc. So this is what you actually came here for today. And that is that how do erythropoietic stimulating agents work, is that hemopoietic or erythropoietic precursors have receptors for erythropoietin, and it drives differentiation and red cell production, accelerating the process of red cell production. It's what's really nice about using growth factors in red cell production versus other types of growth factors is that once you've made a red cell, it's got a 90 to 100-day survival. So if you can get it up, then the impact is significant, and they're less fluctuant than like GCSF or even to some extent thrombopoietin. So what are they? There are a whole lot of different ones. There's EPO alpha, EPO beta and theta, and darbepoetin alpha. Okay, there are some biosimilars that are approved, and their main indication that we're talking about today is the treatment of anemia and reduction of transfusion requirements in adults that are receiving chemotherapy with non-curative intent for solid tumors, malignant lymphoma or multiple myeloma. There obviously are some applications in pediatrics, and there are some other, and there are applications in renal dysfunction where EPO is not manufactured properly, and there are a number of newer agents that are perhaps useful in inherited and malignant bone marrow failure syndromes, but we're not going to talk about those today. The starting dose, what I always do is I actually start quite high, and then if the hemoglobin comes up quickly, then I taper back quite quickly and monitor because if you see the patient and they've got a hemoglobin of 12, it's not going to just crash if you suddenly lengthen the time between the dosing of the EPO. I also quite like the darbepoetin because it fits nicely in the cycle, but of course it is a much higher dose usually, although you do get lower doses. But medical aids are funny; they kind of off, like the doses are depending, on the amount of the drug. This is in the oncology basket, and those ones are in the renal basket. So it can be quite difficult to shift and motivate for things that are outside of your basket. So then I just lengthen the time between them. We see that often these patients recover quite quickly. And if you think they're going to respond quickly and easily, then I tend to use the EPO alpha or beta. And if I think it's going to be a bit tougher, then I give them a bigger whack with the darbepoetin and then push it. Also, because it can be given every 3 weeks or even every 4 weeks, you can time it with the patient's chemotherapy, just like we do with pegylated GCSF. You just give it after the sort of day 5 or so after the chemotherapy is completed, and that way you get the best response to it. Okay. The long acting lasts longer, and as I say, you can dose that every 3 weeks. And the others we can dose weekly. You can increase the frequency of the dosing, but generally speaking, I find that it works better just to give a bigger dose at least once a week. Sorry, I'm just busy looking at a quote here. Right. So I don't really use it daily, but sometimes every other day in patients like Jehovah Witnesses. We had one recently who had malaria and quite severe malaria and dropped his HB to about 4.5, and he responded well to alternate days of EPO alpha. And in that sort of situation, you don't really want to use a long acting because you don't have control and you don't know where you're going to go. So you want something short acting, you're going to get the level up. But particularly in the myelodysplastic syndrome patients, I quite like the long acting. I find that it's easier to administer and it actually gives you a very good result. So as I mentioned earlier, it's made by the kidneys. The kidneys measure the oxygen level, and when it's a bit low, stimulated. We've seen that a number of times. And if you compare that to the transfusion graph, this is the kind of response curve that you get. Hopefully not in the 14s. I think that just shows you just being a little bit overzealous, but at least you get the level up. And as I mentioned, these cells are long acting and so or long surviving, and so the curve tends to be much smoother. The patients feel better, because their hemoglobin's always above 10. It's not above 10 for the first week after the transfusion and below 8 for the third week after the transfusion. And so you tend to get this much more physiological response, and you get a better kind of impact on quality of life. So just to summarize the different interventions for chemotherapy-induced anemia, you've got the transfusions, which we give when the patients are symptomatic. Certainly start thinking quite hard about it when the HBs drop below 8. And if they have serious comorbidities, you may push that trigger a little bit higher. As I said, South Africa has shifted over the last years, and we've moved much more to a single unit transfusion policy. But still, some patients live far. They depend on other people to bring them in. It's difficult to bring them in frequently for one unit, and then although you may get less benefit per unit, you still get a longer period of response if you give more than one unit. The main advantage is it brings the hemoglobin up quickly, and that sorts out the symptoms. The main risks are, as we've discussed already, about the increased risk of infection, iron, and immune reactions like Charlie. Oops. Erythropoietin, one should consider when the HB drops below 10. It can significantly reduce your red cell transfusion requirements and diminish the severity of the anemia and improve the quality of life. Main risk is increased thrombosis, and also there are some less common side effects like hypertension and seizures. I have seen 2 patients with pure red cell aplasia, both with the same molecule, but I'm not going to mention it because I don't think that's statistically important or significant. But it's very difficult to treat, very difficult to manage once you've got a pure red cell aplasia in a patient who's got a malignancy that's receiving chemotherapy, and it means that they need a lot of transfusion. They get alloimmunized and iron overload very quickly, because pure red cell aplasia is a lot worse than chemotherapy-induced anemia. But it's rare. I mean, as I say, in all my years, I've seen 2, but that doesn't mean that it doesn't happen. It certainly does. Intravenous iron should be given if there's an absolute iron deficiency or a functional iron deficiency. As I mentioned earlier, you want to make sure that the numbers are reasonable, not just above the lower limit of normal, especially for women whose lower limit of normal is probably artificially abnormal. You can consider it a little bit higher whilst the hemoglobin is still a bit, closer to normal, around about 11 or so, 11 to 10. And what's important here is that you really should consider that if you're going to give an erythropoietin, that you should give iron, especially unless the iron level is above the normal ranges. Then you don't need to. But if the iron level is even in the normal range, giving IV iron with it improves the response substantially. You are at risk of iron overload. Remember as well that if you start off with a hemoglobin of 14, say, and then you get chemotherapy-related myeloid suppression, and you don't make enough red cells, and your hemoglobin drops to 8, 6 grams per deciliter of hemoglobin worth of iron needs to be stored in your body. And so your iron stores look like you're a bit overloaded. So don't get too worried about patients that have a little bit of, sort of slightly raised ferritin, etc., when they're anemic. Even B12 deficiency or something will give you a raised iron level because because that iron has to go somewhere and it's not in the red cells. But and you do get some reactions with IV iron. They're not that common, but they are well described. Okay. So just to recap on this whole thing, if you've got cancer and kidney disease, you can use erythropoietin. You can, patients who are undergoing palliative treatment or receiving myelosuppressive chemotherapy without any other identifiable cause of the anemia. So a very important point. It's so easy to be blinded by the seriousness of the patient's cancer that you forget that they may have other reasons to be anemic. And so you have to at least exclude those and potentially correct them before you start fixing the chemotherapy-related anemia. And we touched on patients that refuse blood transfusions. And every now and then we talk about, should we do a study on this? But we've got a number of cases that for religious reasons have not wanted blood transfusions and who have actually done quite well with, they've done quite well with growth factors. And what we've noticed is that they get virtually no infections. They can become quite anemic, but they get very, very few infections. And it tells you that the transfusions are not without their risks. What we've had a couple of, and I'm sure that you all have, is people who don't want to get blood from patients that have been vaccinated against COVID. And we're still seeing that. And I mean, we can't guarantee that. So then we say, well, then we can't do that. So, but people who, for religious reasons, don't want to take blood do seem to do quite well, besides the fact that they become very anemic, and obviously that poses a risk on its own. Patients receiving myelosuppressive chemotherapy with curative intent should not receive erythropoietin. And the reason is that there are a couple of studies and meta-analyses that show that there is no survival benefit and maybe even a survival compromise based on the risk of thrombosis. So in that situation, you have to be very cautious and think twice about using it. But and then also patients receiving non-myelosuppressive therapy, they say there's not enough evidence. But I think all of us have seen patients that are getting, drugs like anagrelide, drop their HB a little bit. The JAK2 inhibitors are quite interesting because the way EPO works is it uses the JAK pathway. So if you give EPO, you need to understand that its benefit will be blunted, but nonetheless, there may still be some benefit to doing that. And then patients who are not receiving any kind of therapy for their cancer, will it help to give them EPO? And I think that depends very much on each individual circumstance. Patients with secondary myelofibrosis, extensive GRT, bleeding, etc. This says the same thing as I do. It's quite handy as I've just been going through. It's quite handy as a card, but it's impossible as a slide. So what I want you to take home, you have to ask questions to get us through 5 o'clock, is that you can use erythropoietic stimulating agents in chemotherapy-induced anemia when the hemoglobin drops below 10. Okay. It's a number to kind of trigger you to think. But if patients are a little bit, they have comorbidities, they're quite symptomatic from their anemia of 11, I think it's reasonable to give them a trial of something like that and of an EPO and to see if they respond. In that case, you might prefer to use a lower dose or a shorter acting EPO, but otherwise the long acting is just a little bit simpler. You can use transfusions, and you can use them in combination. Transfusing somebody doesn't mean that they won't respond to EPO. And you want to make that decision based on clinical factors. It works quickly. The patients drop their blood quickly. Sometimes you need to move fast, and so transfusions are the way it works. Don't forget to exclude other causes of anemia. Even if it seems pretty obvious that this is the main thing, you still need to do the basic things. You must replace iron, even if they're not deficient, as long as they're not excessively replete, because it helps the response in the EPO. And you have to recognize and manage that there's an increased risk of thrombosis. Remember, the cancer patients already have an increased risk of thrombosis, and some types of cancer patients and some kinds of chemotherapy, like, for example, the IMiDs, increase the risk of thrombosis substantially. And if you're going to be using this as well, then perhaps things like aspirin are not adequate anticoagulation. One has to be very cautious using this in curable malignancies. They're not licensed for that use. There's evidence and recommendations not to. So you have to have a good, strong reason that's well documented to do that. And then if it's not working, stop doing it. And I put down 6 to 8 weeks, but if you've got somebody who, for example, has a myelodysplastic syndrome and you start them on EPO and it's not working, but you've also put them on azacitidine and venetoclax, and then give it a bit of time, because if the disease starts to be brought under control, then hemopoiesis may improve, and then they might well respond to the treatment. But if you really are just bashing your head against a brick wall, then stop. I mean, if rather give the patient blood than spend money and time and expectation on a drug that's not working and isn't going to work. If it's not working by 8 weeks, it's probably not going to work unless there's some other factor that's busy changing. Aspen is really worried, so they want me to give you 2 disclaimers. And that is it.
Thanks so much, David.
No, thank you for inviting me.
Thank you very much for the overview. And I see we already have some comments and questions in the chat box. let's start at the top. So I think you did speak to the question about radiotherapy. Right. So Garrick Lorden asks whether patients of Jehovah's Witness faith are allowed to re-accept directed transfusions or blood from cell savers. Garrick, not 100% sure. And if you want to speak up, you're welcome to explain what you mean by re-accept. So directed transfusions would usually be transfusions from family members that are directed towards the particular recipient. Cell savers is certainly accepted by Jehovah's Witnesses and encouraged, as a matter of fact, as is erythropoietin. But David, maybe you've got an idea on that?
Yeah, so there seems to be no clear, like, hard line here. I mean, some Jehovah's Witnesses will accept stem cells, for example, but not red. None of them will accept red cells from just somebody else. And as far as I know, they don't generally accept directed transfusions from family members. But some will accept platelets, for example, and stem cells. We are perhaps a little bit disingenuous in that situation, in that we fail to mention that there always are a few red cells in the collection, in the harvest. But you know, it's always a bit difficult in these situations, and we're not overly keen on doing transplants in patients who don't give us that like freedom to transfuse, because if you analyze your transplants going back over time, there's a very small proportion of patients who don't need transfusions, and they always people who are, and we've done this in the Jehovah's Witnesses, people who are nicely in remission, often with drugs like azacitidine. So, you know, we've had erythroid leukemia, we've had a relapsed inversion 16, you know, but patients who back in remission with normal counts when you start. And I think they're the kind of patients that you might well consider. But it's, you know, they have to understand the risk that they take. And it's amazing what some people can tolerate, you know, in terms of how low can you go without transfusion. And somebody shared on the group the other day the trigger for thrombocytopenia transfusion, and also whether cyclocapron had a role to play in that. And it wasn't dramatic. It really wasn't dramatic, the difference between the patients who received transfusions and those that didn't, and their bleeding risk, and those that received cyclocapron and not. There certainly was no discrepancy. But we used like reduced intensity conditioning regimens and that sort of thing. But we've had a few patients that we managed to get through intermediate dose cytarabine. We've had patients that have achieved remissions and either not been transplanted, or even a few that have been transplanted. And as I say, the striking thing that we've noticed is that they get very few other complications, very few infections in particular. And the radiation stuff is the way I understand that is that if you don't have enough oxygen in the tissue, then the free radical generation by the radiotherapy, the energy, isn't transmitted adequately to the tumor. And so you do a bit better if you're not too anemic. But of course, once you go too high, then you start running the risk of thrombosis. But the other, I don't know if that's...
Yeah, no, thanks, David. Let's see. Yeah, so one thing, just another comment. I see Karen say some Jehovah's Witnesses will not accept cell salvage, but there's significant variability within the community. I think one of the things that is usually insisted upon for many is that the circuit should not be broken, that as blood is taken out, that it's in a single circuit and goes back in. That's why autologous transfusions is generally not accepted, but might be accepted by some, where blood is stored in advance prior to surgery. But there is indeed quite a bit of variability. Right, yeah, I have to agree with you. Our experience as well, even though generally the recommendation would be that a hemoglobin cutoff of 7 is no worse than a higher cutoff. Nobody has actually tested a lower cutoff in hematological malignancies or transplant. We certainly do not follow that very strictly. We tend to look at the patient symptomatically. If they have symptoms or are tachycardic, we'll transfuse them. But it generally means that they transfused, for most younger people at least, in the roundabout HP of 5.5, maybe 6. And so we use much less blood than what I was used to using previous to this policy, a lot less. And especially in autologous transplants where you start with a nice HP of 12 or 13, you can often get through a whole transplant with 0 or 1 transfusion, perhaps. I'm talking about red cells. Platelets might be more challenging. But that said, platelets, I think we will see will become much more or much less frequently used when the new guidelines come out. But we'll keep that for another day.
Yeah.
Right, let's hear. Are there any other comments or questions? And please, you're also welcome to speak up. You don't only have to use the chat box.
Just remember that the other issues, like your ability to tolerate anemia is lower if you're septic. It's lower if you and your ability to you don't have reserves. So if something else goes wrong, you do have a significant epistaxis or something, then you and the tachycardia, how you feel. But yeah, mostly people are at rest when they're in hospital like that, and that's different.
Yeah, and monitored, and there is oxygen and all sorts of things. That's great. Okay, so I think one other comment that I had was I just want to emphasize the point you made about giving the ESAs and the IV iron together, because with the ESAs you are pushing sudden red cell expansion, which will need extra iron and will be ready to receive it. And similar to in chronic kidney disease, that's exactly when you want the iron ready and available, where your IV iron is very useful. Great. Okay.
Also to replace the folic acid and B12,
Absolutely.
and vice versa in any of these deficiencies. As the patient kicks in their bone marrow, they really need those things. So yeah.
Certainly. And it's something we often forget is that vitamin B12 deficiency is very common in hematological malignancies. It's been described to be very common in myeloma, for instance. So something that should be routinely looked for in myeloma. And also, let's not forget that vitamin D plays a role in erythropoiesis. And it's something that is not taught much at all, where if you go look at some of the Mayo Clinic data, you'll find that about 50% of myeloma patients are vitamin D deficient. And we often don't even think about testing it. Now, my experience in the Western Cape is that about a third, at least, of patients seeing me in general are vitamin D deficient. I think we've been so, I don't want to use the word indoctrinated, let's say educated, to use sunblock and hats and balaclavas in the summer that we actually often falling behind on vitamin D. So think of all these things. They are all important. Good. So with that, thank you once again. For those who came late, I want to just ask you all to please complete the feedback form, which is really useful for future purposes. Please remind all your friends about the Hematology Oncology Symposium happening in Cape Town on the 13th to the 15th of September. It's going to be great. Please invite the hematopathology colleagues as well, because this is really going to be something for everybody. And we're really looking at what are the new and exciting developments as we're going forward in hematology in the coming years, with great speakers from all over the world. So we look forward to seeing you. With that said, a lovely afternoon to everybody. And thank you again, David. Thank you to the team who prepared all of this. And those who want to watch it again, it will be on the Blood SA website.
And
Bye-bye.
thank you for sponsoring the talk today. Their products are, oh, better not get this wrong, eh? Their products are Anaemia and Nplate. So thank you very much.
Thanks, Aspen. Thank you, David. Bye-bye, everyone.
Bye.